My name is Dr. Kanungo. I'm one of the movement disorder neurologists at Fraser Health. I've been asked to talk to you guys today about things that are beyond just the tremor that presents in some people with Parkinson's disease, but not all people. We're going to touch a little bit on some of the motor symptoms, but we're going to spend most of our time talking about non-motor symptoms of Parkinson's disease. These are not inclusive of all possible non-motor symptoms, but these are the most common ones. The intention of today's talk is to help better understand the wide array of symptoms that can present in this disease that is really not just a nervous system disorder, but a multi-system disorder. So my disclosures, I have served as a consultant on advisory boards for some of the products whose companies manufacture them. I'm not a patent holder, shareholder, or financially invested in any of these products. So starting off with a question, what is Parkinson's disease? Is it simply a disease which makes you shake? Is it a disease which makes you stiff and slow? Is it a disorder which affects multiple systems and leads to dysfunction in thinking and memory, along with problems with sleep and mood, control of bladder function, control of blood pressure, and constipation? Or all of the above? And I guess you all know that it is all of the above. So introducing today's topic, non-motor symptoms may appear during the course of Parkinson's disease, but they're also very common before the motor symptoms emerge. Some of these symptoms can emerge as early as a decade or even before, indicating that the disease pathology occurs much earlier than what we appreciate when we see the motor symptoms start to occur. These symptoms progress in both severity and diversity as the disease evolves. And overall, this early period before the motor symptoms present is known as the prodromal period. These non-motor symptoms are often misdiagnosed and can often be unrecognized and untreated. If untreated, they can also impair quality of life and represent a major cause of hospitalization and long-term care placement. So this graph here is showing the sequence and timing of the development of some of these non-motor symptoms. Obviously, there can be variability between patients with Parkinson's disease. As people know, there are many flavors of this problem. And one of the differences in how people with Parkinson's present is that there can be differences in progression, including which symptoms occur, in what order they present themselves. So take this as more of a general statement. So the prodromal stage, very common symptoms that we'll see in this early period, and 2 to 5 years is a conservative estimate. Some people can even present with symptoms even further back, a decade or more. So common prodromal symptoms include the loss of smell. Now, of course, with COVID having occurred, loss of smell is now a very common symptom. And the most common reason for that would be cigarette smoking. Sleep disruption, including restless leg syndrome. Now, this is a problem that can occur in people without Parkinson's as well. And REM sleep behavior disorder. This is a problem where people start to talk or even interact with and move during their dreams. This is very much an abnormal problem, and it is very strongly correlated with the later development of a Parkinson's disorder. Other prodromal features include depression or constipation, but again, these are rather vague non-motor symptoms that can happen in people without Parkinson's as well. So in this prodromal stage, non-motor symptoms develop insidiously years before the onset of the motor features. Then you get the early motor stage, some early symptoms that can show up here: fatigue, reduction in the volume of one's voice, problems with fragmented sleep. So this early by this early motor stage, it's estimated that about 50 to 60% of the dopamine producing neurons have been lost. Then we get into the stage where most people start to get diagnosed. The motor symptoms have appeared, they've become stiff and slow, they might have developed a resting tremor, and they might have started shuffling their feet. There may be early changes in swallowing function, resulting in mild problems with swallowing pills or swallowing liquids or certain textures. There may be problems with feeling a little bit lightheaded when standing up. There may be problems with short-term memory and also increased nighttime urination. In the very later stages of the disease, 5 to 10 or even longer years after the diagnosis has been made, some patients can present with dementia and psychosis, and urinary problems can become more problematic and result in incontinence. So today we're going to focus on these non-motor symptoms of Parkinson's disease and the less common motor symptoms. The focus will be on how these symptoms can be better managed through conservative approaches, and where necessary to introduce some of the medications that we can also use to help suppress these non-motor symptoms. The emphasis is also on how multidisciplinary care teams, which include physiotherapy, occupational therapy, speech and language pathology, dietitians, and social workers, can also aid in better managing these non-motor symptoms. So the first one we'll talk about is constipation. Constipation occurs in at least 58% of people afflicted with Parkinson's disease, and this is probably a conservative figure. It's thought to result from a combination of a neurodegenerative process that affects gastrointestinal motility. The disease in many people is felt to start in the primitive nervous system of the gut, damage the neurons there, and then spread upwards via the vagus nerve into the brainstem where the dopamine-producing neurons are. So some of the early changes that we see, constipation, loss of motility, these reflect the dysfunction that's occurring in that primitive nervous system of the gut. There can be also delayed gastric emptying, and this occurs in about 70% of people. This can lead to a feeling of feeling full very early before finishing one's meal. This can then subsequently lead to a reduction in calorie intake and weight loss. There can be altered or even reduced absorption of Parkinson's medication, which makes them less effective when people are highly constipated. So, discussing constipation remedies. The very first ones, and the most important by my opinion, is that a lot of folks who show up with constipation in the context of Parkinson's are dehydrated. So the very first thing that we need to get people to do is drink more fluids. On average, the active human body loses about 2 liters of fluids a day. And so you have to replenish with at least 2 liters of fluid a day to keep up with the losses. If you start to get more and more dehydrated, the blood circulation will need some more fluid in order to keep the blood volume up. So it takes that fluid from the gut, and this results in the stools becoming very hard and firm and difficult to passage. When we're talking about hydration, we're not talking about tea, coffee, or alcohol. These beverages will increase urination and will increase the volume deficit. So we're talking about juice, milk, water, even sports or electrolyte drinks. All of those would be okay. The other thing that's a piece of advice in terms of conservative management of constipation is to be more routine with going to the washroom. Schedule a time to go and sit on the toilet and try and pass stool every day. It's also recommended to eat foods that are high in fiber. Prunes are nature's laxative and are highly recommended. Additional recommendations including bran flakes with psyllium fiber, flaxseed, Lots of fruit, particularly this time of year when fruit is quite plentiful. High fiber cereals and bars, a very common one that is popular with the Parkinson's community is Red River cereal. And also to reduce low fiber foods like baked goods and fried food. If necessary, over-the-counter remedies can also help with constipation. We'll start with stool softeners. If the stools are hard and difficult to passage, then bulking them up with a stool softener like Metamucil or Docusate can help the stools to pass more easily. If the stools are taking a long time to passage, then a bowel stimulant might be in order. So this would be triggered if you have had no bowel movements occurring for 3 days or more. Something like Senecot, which comes in multiple different ways with suppositories, syrup, tablets, and also Dulcolax. These are examples of pure bowel stimulants. And then you have laxatives, which combine the effects of a stool softener and a bowel stimulant together. Very popularly, Restoralax is used by the Parkinson's community, but also lactulose and polyethylene glycol are also examples of laxatives that can be used. And where necessary, suppositories or digital disimpactation can also be employed to remove some of the stool from the rectum and get the stool to flow past the rectum and out. Where necessary, neurodegeneration prescription medications can also help with dysmotility. Examples of these are linaclotide and prucalopride. These medications came out a few years ago and are gaining widespread use among Parkinson's community for their role in being able to help some people with dysmotility. So the next non-motor symptom that we'll talk about is urinary urgency, frequency, and nighttime urination, otherwise known as nocturia. So most people with Parkinson's will develop some degree of hyperactivity of the bladder wall muscle, which causes the feeling of urinary urgency and frequency, leading to more frequent urination during the daytime and particularly during the nighttime. Especially during the nighttime, with frequent getting up and going to the bathroom, this can increase the risk of falls. So conservative measures to manage urinary urgency and frequency: don't drink any fluids 1 hour before bedtime. Schedule bathroom breaks during the day. Wearing incontinence pads or diapers. Having a bedside commode to make the trip a bit shorter. Instead of having to go a long trip all the way to the bathroom, having a bedside commode can shorten that trip and therefore decrease the risk of falls. For men, a condom catheter can be considered. This is a type of catheter with a condom at the end that is placed over the penis and allows one to simply pee into a bag without having to worry about getting up to go to the washroom at night. Medical treatments include older generation medications like oxybutynin and tolterodine. Note that there have been no randomized control clinical trials in Parkinson's in people with Parkinson's. So we do know from use of these medications in people with Parkinson's that they can cause side effects such as cognitive concerns and worsen constipation. Neurodegeneration medications, including mirabegron and sulfasalazine, are much safer and have been proven to reduce urinary urgency, frequency, and nighttime urination. Notably, neither of these neurodegeneration medications, however, are covered under pharmacare. Cost of mirabegron has come down quite a bit since it was introduced, but sulfasalazine, otherwise known as Vesicare, is still a little bit expensive. If one has failed oxybutynin, then they can get coverage by BC Pharmacare for this latter medication here. The most effective treatment for neurogenic bladder in Parkinson's disease is the injection of botulinum toxin into the bladder wall. Botox is a medication that when injected into a muscle causes that muscle to stop spasming. And it's that spasm of the bladder wall that causes this feeling of urinary urgency and frequency. This has to be done under the guidance of a urologist who goes in with a cystoscope into the bladder to visualize the bladder wall, which is then injected very rapidly. The entire procedure takes approximately 5 minutes. The next non-motor symptom that is very, very commonly experienced in people with Parkinson's is dizziness. And when we're talking about dizziness in Parkinson's, what we really mean to say is that the person is feeling lightheaded after standing up due to a drop in one's blood pressure, such that there is not enough oxygenated blood being pumped by the heart to the brain. The brain needs a certain amount of oxygen, and if it doesn't get that oxygen, there is a reflex protective mechanism that makes the person go flat, and this is what fainting is. So again, orthostatic hypotension. This is low blood pressure upon standing, feeling dizzy or faint when you stand up. It's a very frequent but undertreated complication and occurs in at least 65% of people with Parkinson's, but a very small proportion of people who suffer with this will receive treatment. Now, most of the time, the symptoms are mild, and they simply reflect a state of dehydration. And one uses that as a reminder that they need to stay well hydrated. But sometimes it can become very severe and can cause people to faint and fall. In terms of management, the first conservative measures would be behavior modification, getting up slowly, and giving some time before taking those first steps to make sure that the blood pressure has stabilized. Increasing hydration and also increasing dietary salt, particularly if your baseline blood pressure is starting to get lower and lower. Another thing that should be mentioned is often people come to Parkinson's disease with a history of high blood pressure. Parkinson's tends to lower one's blood pressure, so the blood pressure should be constantly reevaluated as you go through this journey with Parkinson's, in order to see whether or not you still need those antihypertensive medications. If the baseline blood pressure is coming down, then maybe it's time to reevaluate the antihypertensive medications. Once things start to become more severe, and in order to reduce the risk of falls occurring from fainting, compression stockings and or an abdominal binder becomes necessary. Additionally, the use of a cane or a walker and referral to an occupational therapist to learn how to properly use one of these assistive devices is also recommended. So when we're talking about compression stockings, we are talking about above the knee compression stockings. You have to squeeze the fluid in the legs above the knee to where the big veins are in the thigh in order for that fluid to be collected and returned to the heart in order to increase the venous pressure and therefore the systolic pressure. So the only effective compression stockings at doing that are ones that are worn above the knee as high up as they can go. They should be 30 to 40 millimeters of mercury in compression. Some recommended brands include Sigvaris and Jobst. A couple of tips in terms of trying to put the compression stockings on more easily is to wear nitrile gloves. The tips of our fingers, especially if they're kind of rough, can stick to the compression stockings, making it difficult to roll the stocking up your leg. So wearing some nitrile gloves on your hands can make that much more smoother. The other recommendation for helping to put compression stockings is to use a donning aid.
In order to use this Butler donning device, in order to put on your compression stockings, you're going to start by rolling the top of your compression stocking over the top of the Butler. Using the palms of your hands and avoiding using your fingernails, you're going to roll the stocking down over the device. Until you have the heel rolled over the device facing you and a nice toe box area in there. You'll place your foot directly into the stocking, into the butler, step down onto the floor, and pull the stocking up by using the device. The butler can be used by both men and women for knee highs or thigh highs. It can help in not having to bend over so far to put your stockings on, as well as to avoid snags that can occur from jewelry, watch bands, or fingernails.
So a very good supplier of compression stockings, as well as somebody, a store that would have one of these devices in stock to demonstrate, is Nightingale Medical Supplies. They have locations all across Lower Mainland BC, as well as in the island and also in the interior. In the store here in White Rock, I've noticed that they have one of these butlers in their store. And so they have people there who can help you learn how to use one of these to be more effective at placing the compression stockings on. So other treatments for orthostatic hypotension or low blood pressure upon standing include domperidone. This medication blocks the peripheral dopamine receptors and can help to counteract the side effects of Parkinson's disease medications, including levodopa, which can in some people further lower blood pressure. By giving the levodopa together with the domperidone, it acts almost as an antidote medication to prevent blood pressure from falling. Two other medications that are used to artificially increase one's blood pressure include fludrocortisone or Florinef, which is a synthetic mineralocorticoid that mimics the action of aldosterone. Aldosterone is the hormone that our bodies release to drive up blood pressure. And also another medication called midodrine. One caution with these medications is that when you lie down, you can get high blood pressure. And so if one is on these medications, it's important to be dynamically checking blood pressures lying down, sitting up, and also standing up. The next topic is that of pain. So it's a bit of a myth that Parkinson's is not a painful disease. Pain is actually a common feature of Parkinson's and is underreported. The pain often occurs when the person is in the off state between doses of levodopa. The basal ganglia is involved in sensory function through the modulation and integration of information from primary processing structures of the brain. The loss of dopamine signal in the basal ganglia is thought to, in some way, alter sensory perception and change pain thresholds. However, dopamine-stimulating medications like levodopa don't always eliminate pain for people with Parkinson's. So some examples of pain that is experienced in this disease: dystonia. This involves overactivation of muscles, which causes twisting of a body part around a joint. So in this case, we're seeing very significant toe curling, and in this case, we're seeing foot turning. This is an example of dystonia of the feet, which is a very common version of dystonia in Parkinson's. And when it occurs very severely, it can be quite painful. Another type of pain experience is due to mild peripheral neuropathy that can develop in people with Parkinson's, causing neuropathic pain. Another example is carpal tunnel syndrome, because it is very common in Parkinson's, especially in those who have tremor, to get compression of the median nerve that runs through the carpal tunnel in the wrist. For management, one of the first things we try to do is try and figure out, is the pain occurring during off periods? Is there some temporal relationship between the timing of when you took your last dose of levodopa and when the next dose is due? If there is, then the thing we try to do is try to optimize the anti-Parkinson's medication regimen so that there is no fluctuations, there is no off time. Advanced therapies which can help to do this include rotigotine patch or Nupro patch, duodopa intestinal pump, Vyalev subcutaneous pump, or deep brain stimulation. Painful rigidity can also be managed with regular stretching, and this is where physiotherapists and personal trainers come in to show you how to do stretching properly. Painful dystonia can be treated with botulinum toxin injection. Again, Botox is a drug that weakens muscles. And so when injected into the muscle that's overactivating and causing the body part to twist, that can reduce the overactivation of that muscle, reduce the twisting, and therefore reduce the painful turning and twisting of the body part. Peripheral neuropathy can be treated with nerve-blocking medications, and these are some common ones like gabapentin, Lyrica, amitriptyline, and topiramate. And carpal tunnel syndrome can be treated with splinting, or if it is severe, with carpal tunnel release surgery. Next is swallowing difficulties. This affects more than 80% of people with Parkinson's and can complicate things like taking one's pills, can lead to malnutrition, and in most severe cases can lead to aspiration pneumonia. The underlying mechanisms of what causes problems with swallowing are poorly understood. We just don't understand the mechanisms of how all those muscles and the nervous system work to coordinate swallowing very well. Assessment by a speech-language pathologist is necessary in order to identify who is at risk for developing aspiration and pneumonia. There are a couple of ways that a speech-language pathologist will do this. One is with a video fluoroscopic swallowing study, and another one could be with fiber optic or endoscopic evaluation of swallowing, which is done together with an ear, nose, throat doctor. Management of swallowing problems can include optimizing the Parkinson's medication if the swallowing problems predominantly occur when the person is wearing off. Changing to softer textured foods or a minced diet with thickened fluids can also help, and this is where referral to a dietitian to ensure adequate calorie intake is important. Swallowing therapy by a speech-language pathologist is the gold standard treatment of Parkinson's disease-related swallowing problems. Unfortunately, really high-quality studies are rare. You may have seen that there are some devices that have been proved to help training with swallowing difficulties. This is an example of one that uses expiratory muscle strength testing. A limited randomized control trial did not demonstrate significant improvement of swallowing safety. Video-assisted swallowing therapy has also been looked at. This involves visual biofeedback cueing to improve the coordination of a person's swallow, and this has shown some modest improvement in quality of life and reduction in residual food left after swallowing. Very few people with Parkinson's will develop difficulty swallowing severe enough to require a feeding tube. I can count on my hand of the 3,000 or more people that I've followed with Parkinson's. I can count on one hand the number of times that things have progressed to the point where a feeding tube is required. This is a very, very rare complication and does not happen in most people with Parkinson's. Next, we'll talk about speech difficulties. So the soft voice is very common to pretty much everyone afflicted with Parkinson's. Though their own voice may sound fairly normal in their own ears, and that's because we hear ourselves through the conduction, through the bone, through our skull, whereas other people hear us through conduction through the air. The reason why people get this soft speech is due to alterations in muscle tone and control of the speech muscles that underlie how we produce volume. This, again, occurs in over 90% of people afflicted with Parkinson's. Management, well, the Parkinson's medications do not improve speech at all. This is where referral to a speech therapist for Lee Silverman voice therapy is the most important measure that we can do for speech. The current iteration of LSVT is LSVT Loud. There are online classes available through Parkinson's BC, but also in-person classes available with certified speech language pathologists who can teach you the techniques that LSVT employs in order to help folks with Parkinson's better project their voices. Speech aid devices, these are things that can play kind of white noise in your ear when you're talking, and they turn off as soon as you stop talking. These make people speak louder with that white noise playing when you're talking, and also make people speak more slower, which is another problem in Parkinson's. People often tend to speak too fast. So speaking slower and more clearly can also help with better enunciating one's words. Drooling. So drooling, the medical term for which is sialorrhea. This is due in part to the stooped posture, which results in pooling of saliva near the front of the mouth. In actuality, people with Parkinson's produce less saliva than people without. The back of the throat needs to be wet to stimulate involuntary swallowing. And so if you're pooling all that saliva in the front, then the back of the throat is dry and then you stop swallowing and swallowing down the saliva. So management, conservative measures, sucking on a hard candy or chewing some gum. Putting in a hard candy gets the mouth working and gets that saliva swished to the back of the throat, which wets the back of the throat and triggers that involuntary swallowing. Medical treatments, including atropine drops, can reduce the production of saliva from the salivary glands, but they tend to make this residual saliva kind of sticky and thick. Another use for Botox includes injection into the parotid glands right behind the angle of the jaw and the submandibular gland just underneath the jaw. Saliva glands also can be turned down by injecting Botox into them. And so this is a measure that can reduce the amount of secretions that one is producing. Sleep difficulties. So sleep difficulties occur in almost everyone with Parkinson's disease to some degree or another. Very commonly, REM sleep behavior disorder is a preclinical marker of Parkinson's disease that is very highly predictive of whether a person is going to develop Parkinson's later on in life. We now know that if a person with a first-degree relative who has Parkinson's is found to have REM sleep behavior disorder and then is tested with a DAT scan, if they're positive for REM sleep behavior disorder and for the DAT scan, the majority of them will develop Parkinson's within the next 5 to 10 years. The prevalence of acting out or talking during your dreams occurs in approximately 30 to 60% of people with Parkinson's. The first-line treatment is clonazepam, but this benzodiazepine medication can make daytime sleepiness worse and should also be avoided in people with obstructive sleep apnea, which is another common non-motor side effect affecting sleep in Parkinson's. Second-line treatment is melatonin, but this is often what we use first. We often start with a dose of 3 to 5 milligrams and progressively increase the dose up to a maximum of 20 milligrams. Sometimes when starting melatonin, one can notice that the dreams are a little bit more vivid initially, but usually that settles down. Melatonin has to be taken regularly in order for it to keep the REM sleep behavior disorder under control, and it's taken 1 hour before bedtime. Another way that we can treat REM sleep behavior disorder, though, is by increasing the dose of Parkinson's medication at night, which indicates that dopamine does play some role in how this problem of REM sleep behavior disorder is regulated. Other sleep issues include sleep fragmentation. No obvious reason for the person to wake up. They just wake up like an alarm clock goes off multiple times per night. Insomnia means difficulty falling asleep. Restless leg syndrome, a creepy, crawly, unpleasant sensation that usually involves the lower parts of the legs, occurs when the legs are at rest and goes away when you get up and start pacing. And akathisia, which is a medical term that just indicates the person is generally restless. And again, obstructive sleep apnea. Excessive daytime sleepiness occurs quite commonly as well, and it's also important to note that sleep attacks can occur with dopamine-stimulating medications, including levodopa. If one is consistently falling asleep every time they take their dose of levodopa, they may be suffering from sleep attacks caused by the medication. Management would be a stimulant like modafinil, which is generally considered safe and well tolerated by people with Parkinson's. Caffeine is also a stimulant that can help some folks with Parkinson's be more alert during the day. Years ago, there was a possible protective effect demonstrated in a large prospectively followed group of men, which showed that there was a 5-fold reduction in risk of developing Parkinson's in men who drank more than 4 cups of coffee a day. This robust neuroprotective effect was not seen in women. Dr. Postuma in Montreal put together a Canadian multi-center randomized control trial to assess whether or not caffeine really does have a disease-modifying effect in Parkinson's. So people were randomized to one of 2 conditions: caffeine tablets versus placebo tablets, and participants had Parkinson's disease on stable medical treatment. They were followed for 6 months, and then after 6 months, they looked to see whether or not there was any difference in their outcomes. What we found was there was no improvement in the motor symptoms by taking caffeine. There was a slight improvement in daytime fatigue, which attenuated over time. So yes, caffeine can help with daytime fatigue, but no, it does not help as a disease-modifying agent. Mood. Dysregulation of mood is a very common symptom and can present itself in many different ways, including a little bit of, say, being a little bit more short-tempered, apathy, or outright depression or anxiety with panic attacks. Depression may in fact be the first manifestation of Parkinson's in some people. And it is often under-recognized as it may be masked by other motor symptoms. For instance, the slowness and stiffness and the loss of facial expression that occurs in Parkinson's can also occur when people are depressed. But because the person has Parkinson's, it's maybe not recognized that the person is actually depressed. On the flip side, one should not just assume that one is depressed simply because in Parkinson's there's loss of facial expression. There is often frequent co-occurrence of depression with other neuropsychiatric conditions like cognitive impairment and anxiety. The symptom profile of depression in people with Parkinson's, though, is different than in people without Parkinson's. People with Parkinson's have higher rates of anxiety, pessimism, irrationality, suicidal thoughts, but no suicidal behavior, and less guilt and self-reproach. Management of depression in Parkinson's. One of the first things one wants to do when talking about depression is to make sure that it's not occurring simply due to on-off fluctuations. Sometimes people can get very anxious when their medications are about to wear off. That being said, the use of levodopa generally does not alleviate depression. The dopamine agonist medications, as well as so drugs like pramipexole, selegiline, these medications can have modest mood elevating properties, but those can also become side effects of the medication if one's mood elevates too much and the person becomes manic. Because of the lack of anticholinergic and sedative side effects, selective serotonin reuptake inhibitors are the preferred drug treatment for Parkinson's disease. These would include medications like citalopram or escitalopram, sertraline, and paroxetine. Apathy is another flavor of mood disorder, which indicates a lack of interest, enthusiasm, or motivation to do the things that one used to enjoy doing. This also occurs quite commonly and may coexist with depression and dementia, but can also be its own symptom independent of those problems. A recent study demonstrated that the cholinesterase inhibitor rivastigmine can help to improve apathy. Anxiety, again, very common in Parkinson's, can be an off-period related phenomenon and can respond to anti-Parkinson's medications if it's occurring in the context of wearing off. But anxiety may also be a prodromal symptom that predated the development of the motor symptoms by several years. Again, there's been no high-quality assessments of anti-anxiety medications in Parkinson's. If the anxiety occurs solely in off times, an adjustment of Parkinson's medications can be very helpful. On the other hand, sometimes people get things like panic attacks, and sometimes they need low doses of benzodiazepines. These should be used cautiously because they can increase adverse effects such as confusion or cause slowing down of the central respiratory drive, leading to a reduction in breathing. And again, SSRIs are useful for the treatment of anxiety disorders, but it's unknown whether or not they're very effective in Parkinson's. What about cannabinoids? So there haven't been any high-quality trials done with cannabinoids in Parkinson's yet. There are some that are currently in undergoing, but their results have yet to be published. Conservative management of mood disorders, and in most head-to-head studies, cognitive behavioral therapies have proven to be as effective or more effective than any of the drugs that we have to treat depression or anxiety. So cognitive behavioral therapies, they focus on challenging and changing thoughts, beliefs, and attitudes and behaviors, along with improving one's emotional regulation and develop better coping strategies that help to target solving current problems. This can be accessed via a therapist like a psychiatrist or a psychologist, or can be done in a group therapy or even online. These resources are available through Parkinson's BCs and our very terrific counselors who work with them. So this comes to the end of my talk, some take-home messages. People afflicted with Parkinson's are affected by both the motor and non-motor symptoms. Sometimes the non-motor symptoms can be even more bothersome than the motor symptoms. These non-motor symptoms include, but are not limited to, problems with constipation, urinary urgency and frequency, low blood pressure or blood pressure which falls upon standing, pain, speech and swallowing difficulties, drooling, sleep and mood problems, along with cognitive decline and even psychosis. Medical management is available to help alleviate many of these difficulties, but treatments need to be individualized for every person with Parkinson's. Many of the non-motor symptoms can be effectively managed by conservative measures guided by trained allied healthcare professionals in physiotherapy, occupational therapy, speech and swallowing therapy, as well as by dietitians, social workers, and psychologists. Another person in the allied healthcare team that can also be very useful is the clinical nurse at the movement disorder clinics, Currently, Island Health, Fraser Health, and UBC, Vancouver Coastal Health, all have very experienced nurses in the employed in the clinics who have a lot of knowledge regarding conservative management of non-motor symptoms. Newer therapies are emerging, which hold the promise of improving quality of life with people with Parkinson's by improving both these motor and non-motor symptoms. So thank you for your attention today. I work at Fraser Health Movement Disorder Clinic. We're located centrally in Central Surrey in Jim Pattison Outpatient Care and Surgery Center. The neurologists in our clinic include Dr. Claire Hinnell, Dr. David Ridds, myself, and we have a new movement disorder neurologist starting soon, Dr. Jason Chan. Our clinical nurse is Robbie Bell. We have 2 physiotherapists, Scott Bishop and Trinetta. We have an occupational therapist, Falana, and a speech swallowing therapist, Julia, and a social worker, Victoria. Thank you again.